study was actually initially inspired by my very own patients from a prior study. So what I'm referring to is actually our study, phase 2 randomized study of looking at intermittent fasting in patients undergoing pelvic radiotherapy. In that particular study, we were looking at the role of fasting versus nutritional counseling as a way to mitigate radiation toxicity. That trial, which was supported by an NIH Early Investigator Career Development Award, has since completed, fully accrued, and is in follow-up phase. But while I was conducting that study, one of the earliest patients I enrolled on the study developed a full classical ST elevation myocardial infarction, so like the big heart attack. And it happened effectively just a few weeks into him starting hormonal therapy. And he had none of the sort of major risk factors of someone who we would expect to have a heart attack. And so when that happened, it really started to trigger me to think about like what are the long-term and short-term consequences of hormonal therapy, and then recognizing that we are not good as clinicians using existing criteria to predict who's going to ultimately have the biggest risk. And so because of that patient, actually, I started to look and follow other patients who are getting hormonal therapy. And even though I'm a radiation oncologist, I actually train at an institution where we are the ones prescribing hormonal therapy. And so this was an issue near and dear to my heart. And as patients are living longer and longer and being diagnosed later and later with prostate cancer, the issue of competing risk in terms of both morbidity and mortality becomes an ever more important issue at the forefront of how we think as clinicians. There are patients that we meet that we think probably really needs hormone therapy, but we think we might actually be shortening their lifespan or causing significant harm to their sort of overall quality of life, that we have to really weigh this, should we do hormone therapy or not, right? But in order to make that informed decision, we also need to know who's going to be at risk. And the fact of the matter is it's easy to identify patients who are quote unquote clearly at risk. You know, they had a prior heart attack, they had prior stents placed, they have a history of stroke, right? So we can identify those patients easily. And so that's one of the patients that I initially met for my other study, and that really made me think about how we can start to address these issues and identify risk factors. And that's what prompted the development of this study and the strong collaboration with my co-PI, Dr. Junhwa Ri, who is a cardio-oncologist at City of Hope. And she and I had been talking about ADT's native effects on the heart and the cardiovascular system and being able to model those risk factors. And so together we had been thinking about this issue for quite some time. And then when I started to run my study and see multiple patients come in with coronary artery disease and related risk factors, and also patients that didn't have risk factors where then they developed coronary artery disease, and it really prompted me to worry about what are the risks patients are actually bearing that we don't know, we're not able to adequately inform them. And so that's what really motivated us to write this study. Question raised by the American Heart Association. Dr. Ree and I wrote a grant that's now funded by the American Heart Association to fund this study. It was part of their sort of like Translational Collaborative Sciences Award program, specifically aiming to bring together clinicians across different disciplines together to think about important questions that are important to address in cardiovascular disease. The reviewers brought up this question too about the concern about muscle wasting, right, as a risk factor related to GLP. And so part of the reason we chose GLP as one of the arms for the study was fundamentally because more and more patients, regardless of whether we had the study or not, were coming in themselves either asking to be on the drug or being placed on the drug as a part of standard of care. And we realized that patients were getting this and we had no information on the long-term or even short-term safety of putting patients on this agent. And so it was an important question to study, and it was almost chosen for us, right, because of this new sort of wave of interest in GLP agents. And there have been a lot of data looking at GLP in reducing cardiovascular disease in patients with obesity and diabetes as prior risk factors. So we thought that this would be a very reasonable drug to study since patients are already coming in receiving them. Part of the rationale for the study was actually to look at patients getting short-term hormone therapy. And actually, we've debated this back and forth, in all honesty, considering whether we should focus just on short-term or short-term and long-term hormone therapy. So to take a step back, patients with prostate cancer are recommended either 6 months or longer terms of hormone therapy, depending on how aggressive their prostate cancer is and also at what phase of their disease. For example, is it definitive treatment, meaning no prior therapy, or are they coming back with recurrent prostate cancer after surgery and receiving what we call quote unquote salvage radiation? So in different contexts, different durations of hormone therapy is recommended. The reason we chose to focus on patients in this initial study on 6 months of hormone therapy is because, interestingly enough, the vast majority of patients who experience an acute coronary event, so we're talking about a heart attack, these kinds of patients, the vast majority are getting these events within the first 6 months, which is counterintuitive to actually how we think about the negative impact of ADT, right? We know ADT has negative effect on muscle mass, on visceral obesity. We know that it has effect also on insulin resistance and glucose control, as well as circulating lipid profiles. All of these things are negatively affected by testosterone suppression. So it's kind of like testosterone is overall a systemic protection, right, for men in terms of all of these metabolic risk factors. But if that's true, then one would guess that the risk of cardiac events will just continue to increase over time if patients are getting, say, 2 years, right? But then why are all the events happening in the first 6 months? Fundamentally, because of this, we are actually not that worried, so to speak, about how much muscle loss is happening in that initial phase, because our hypothesis is that the reason that patients are getting these cardiac events are not because of muscle wasting or even visceral adiposity gain over the course of this long period of ADT, since 6 months is such a short period that clinically we don't actually observe a dramatic change. So to put it in context, if I have a patient getting, say, 2 years of hormone therapy, it wouldn't surprise me if at 6 months into their hormonal treatment, I don't observe substantial weight gain, muscle loss, or increase in visceral adiposity. Interestingly, in such patients, it's not uncommon that after that first 6 months, when their testosterone is actually recovering at like 9 months or 12 months, you actually start to see some of those things because their testosterone is still not fully recovered and they're technically suppressed. And sort of after that initial 6 months is when we start to see those kinds of things that I just mentioned. So whatever is causing this increased cardiac risk, there's some disconnect between our understanding of what ADT does to the metabolism and what ADT also does to the cardiac system, such that there may be a discrepancy in terms of what's actually putting patients at risk in terms of short-term coronary events and long-term coronary artery events. We do really strongly encourage patients to do resistance-based exercise. And that's always been the core recommendation to all of our patients, both that and the fact that strength training and resistance training is important for maintaining bone density as well, right? So for both of those reasons, we do strongly recommend patients continue practice and start practicing resistance training if they haven't been. In terms of what we monitor closely. So because GLP has its own risks related to especially the GI system, and radiation can sometimes cause GI-related toxicities, we definitely have a closer eye on those kinds of things, whether that's nausea or changes in bowel habits and loose stools. But all the patients that are referred to for GLP, and they're randomized to the GLP arm, are meeting routinely with a board-certified endocrinologist that actually specializes in managing GLP. So that's why we don't necessarily need to monitor them so much more closely during radiation, as much as that we have a separate provider that's actually focusing on the possible toxicity of GLP. In terms of what we monitor from radiation standpoint, I actually don't expect a whole lot more in terms of toxicity, in part because nausea is quite rare in terms of radiation-related side effect for prostate cancer. It happens probably in less than 5 to 10% of the patients we see on average. And then more than not, GLP tends to cause kind of a slowing down of bowel function, when during radiation, we actually see more things like diarrhea and loose stools. So they're probably counteracting each other if we were to guess. We haven't seen anything so far. I've treated probably a dozen patients on GLP before, during, or after radiation as part of their standard of care. They're just getting GLP from their primary or from their endocrinologist. And those patients have not experienced sort of out of expectation toxicities. But last thing I'll say is that we are monitoring the patients for muscle mass changes over time. There's body composition measurements as a part of the study, as well as a CT-based, sort of a radiomic-based measurement of central, like visceral versus sub-Q adiposity and a muscle mass measurements, quantifying that using serial CT scans. So there are definitely measures in place to assess whether GLP is having a negative effect on that. Previous study to this one that I mentioned earlier, the phase 2 randomized study looking at intermittent fasting during pelvic radiotherapy. In that particular study, we looked at patients who are getting pelvic radiotherapy for prostate, rectal, or cervical cancer. Now, we had enrolled a much fewer numbers of cervical and rectal cancer patients, understandably for many reasons. They're less common cancers. Patients tend to be more sick. And so it's more difficult for patients to be willing to undergo the study. But also those patients are getting concurrent chemotherapy. So in that particular study, patients who were randomized to the fasting arm did very well. We actually only had one patient who needed to sort of really violate the protocol, so to speak, and need to use like rescue foods, as we call them. But for the most part, people were really fine doing their recommended fasting regimens. And actually, most patients felt that the fasting was easier as time went on because it became very routine for them. And the difference between that study and this study in terms of the fasting is that in that study, we stipulated more details related to radiotherapy because that study was looking at toxicity reduction with regard to radiation. The timing of the fasting was very much tightly correlated with when radiation is given. In this study, that's not the case because we're not really looking at radiation toxicity. And so we no longer enforce these kinds of like strict regimens as to like exactly what hour the fasting is to. We're just more recommending kind of a standard 16 and 8, kind of 16:8, meaning 16 hours of fasting, 8 hours during which all the food or calories are intaken for the given day regimen. And patients are asked to maintain that for at least 5 days a week. But the difference is that patients are asked to do it for the entire duration of the hormonal therapy, which is 6 months. Now, that is a bit more difficult in some ways. However, we do believe, based on the previous data, given how well 23 of the 24 patients randomized in that previous study were able to adhere to the fasting recommendations, we felt that feasibility should not be a problem here, especially since these are all prostate cancer patients. And in fact, arguably because of differences in the enrollment criteria for pelvic radiation, these are more aggressive patients. And so these patients are actually all with kind of lower risk prostate cancer and overall in a very good place in terms of their overall health. So really, these patients should not have trouble adhering to 6 months of fasting recommendations. That said, the difference between what I said earlier and this is that the patients that are recommended to the fasting arm are meeting with a certified dietitian, not only a certified dietitian, but what the specific dietitian that worked with all of our patients during the fasting portion of the previous study. It's the same that this dietitian has had decades of experience working with patients also receiving radiotherapy, many of whom need additional guidelines, recommendations in terms of protein intake, not so much for prostate cancer patients, but some of our patients, including patients getting head and neck radiation and GI radiation, do a lot worse in terms of maintaining their nutrient uptake. And so they do get kind of a weekly dietary recall. We do get food frequency questionnaires from patients and assess kind of what is their overall macronutrient intake. Those are things that we will track. But because we haven't really had a problem with patients in the previous study, we don't believe that this is going to be an outstanding issue here in the fasting patients either. There's still a lot to be said about part of the risk of cardiovascular disease that I think is something that we don't know about in terms of many years down the road, right? Sometimes we stop monitoring these patients 6 months, 12 months, 24 months as oncologists, and we need to figure out a way, ultimately in the long term, is to bring this kind of thinking, understanding, and care to our primary care providers, right? Ultimately, a lot of these patients are going to be cured of their cancer, and we do not have the resources or number of cardio-oncologists, definitely not enough oncologists themselves to be monitoring for all of these late risks. And so I do think that we will need future studies that actually monitor risk 3 years, 6 years, 20 years down the road. This is part of the big problem So we historically used a drug called Lupron or LHRH agonist, and then more recently came up with this drug, which is an LHRH antagonist. Okay. And this new drug, initial studies do suggest there might be lower risk in terms of it being an ADT drug that could lower the risk of coronary artery disease. However, there are limited long-term follow-up, and it's not clear that additional studies are going to be done. And so it remains controversial, fundamentally controversial, whether LHRH antagonists are better than LHRH agonists. And so, as a part of our study, we've allowed for both and stratified to deal with this fact that there are patients that are heterogeneously taking this old drug versus this new drug, and we think maybe there's some data to suggest this new drug is better, right? But I do think it's really important to understand that long-term effects of ADT, I think, are still poorly characterized in the modern era. A lot of patients previously received longer durations of hormone therapy or received hormone therapy without modern cardiovascular care. And so the answers to this fundamental question, for example, of whether we should be using LHRH agonists versus antagonists, that itself is still not known. So I do think that more studies are needed in the future as we think. Even at our PCF roundtable, we were talking about in the modern era with how good prostate cancer outcomes are now. And in fact, even in the metastatic hormone sensitive disease setting, patients are living longer and longer, such that we're now actually worried that patients with newly diagnosed metastatic disease, they have a competing risk and could die of cardiovascular disease, right? And so it really calls into question how we think about prognosticating risk and also long-term follow-up with modern data. And unfortunately, a lot of the data that we have is based on older studies, older trials, and so we don't really know what that risk is in large modern studies. And so I do think that we need future studies to be able to follow these patients further out, have a better understanding of what is the difference between LHRH agonists and antagonists, be able to implement non-invasive or minimally invasive biomarkers into these studies and be able to follow patients in kind of larger scale cohorts that really accounts for things like, well, is a patient at a comprehensive cancer center or is being treated at a network site or is being treated totally in the middle of nowhere, right? And can we remotely deliver this type of care to those patients? And I think that was one of the main inspirations I had for my original study with the fasting intervention, was that if this is a valuable intervention and could be helpful to patients, it's a cheap intervention, right? Telling people when to eat or when not to eat can be easily deployed. And so the idea here is that, as GLP become more accessible to patients, as fasting has been shown to be safe, we want to think about how to bring these kinds of studies to enable for future studies that are cross-reaching, that enable us to deploy them in a telehealth-based manner and actually be able to be more inclusive of patients in the community so that we can really truly represent the disease burden and the disease population that these issues affect.